Okay, good afternoon and thank you for joining us. Welcome to our session on bone sarcomas. I would also like to extend my warmest thanks to our speakers. My name is Ornella Gonzato. I'm the founder and president of the Italian leading patient advocate organization that deals with every type of sarcoma except GIST, as well as a long-standing and currently appointed SPAEN board member. It's a great honor and a privilege to moderate this session today. Bone sarcomas are rare cancers, 8 to 10-fold less common than soft tissue sarcomas. Primary bone sarcomas account for less than 0.2% of malignant tumors across all ages. Osteosarcoma and immune sarcoma mainly affect younger people, children, and adolescents, even if a second peak of incidence of osteosarcoma relates to the 7th and 8th decades of life. Common conventional chondrosarcoma is the most frequent bone sarcoma of adulthood. Chordomas are even rare cancers with a median age at diagnosis of 60 years, even if scalp presentation may affect a younger population, including children and adolescents. In any curative strategy for bone sarcoma, surgical resection of the primary tumor is regarded as the gold standard in a multimodal treatment that combines surgery, chemotherapy, and/or radiotherapy. Advances in imaging modalities and surgical reconstructive techniques have increasingly improved patient outcomes in terms both of local control of the disease and the quality of life. New technologies and new materials offer a range of opportunities, allowing an even more complex surgery through more accurate prediction models, increased precision, and better functional outcomes. Surgical planning and navigation, 3D printing, reconstruction implants are reshaping the orthopedic oncology landscape, providing benefits both for patients and surgeons. But sometimes surgical resection may be highly morbid or impossible. Radiotherapy may be considered in patients with unresectable tumors or as adjuvant treatment of tumors at high risk of local recurrence. Radiotherapy, especially modern radiotherapy, including heavy particles and intensity modulated radiotherapy, may offer important advantages and should be considered where appropriate. Systemic options include conventional chemotherapy. Ifosfamide and doxorubicin are still essential drugs, even if in the recent years, target therapies such as immune checkpoint inhibitors and tyrosine kinase inhibitors have been added. Given the rarity and the complexity of patient management, the accepted standard for bone sarcomas is treatment at reference centers and/or within reference networks, able to provide access to the full range of care and age-specific expertise. A multidisciplinary approach is mandatory in order to identify the most appropriate treatment strategy for each patient. So let's move on to today's program. We have 3 interesting and stimulating presentations. 2 of them will focus on advances in research and medical issues, and the third will concentrate on rehabilitation and mental health aspects during the disease pathway and beyond it. So it's my pleasure to introduce our first speaker, Dr. Andreas Leithner, head of the Department of Orthopedic Surgery at Medical University of Graz, Austria. Please, Dr. Leithner, tell us all about the top 10 research projects in bone sarcomas.
Thank you, Nella. Thank you very much. We'll try to do this here now. Do you see the presentation? Is it okay?
Yes.
Okay, thank you very much.
Okay.
So thank you for the kind invitation to talk here on the top 10 research projects in bone sarcoma. I'm an orthopedic surgeon doing orthopedic surgery for more than 20 years, focused on bone sarcomas and soft tissue sarcomas. So we need him again. So we have little issues. So it only now works with this one. Okay, thank you very much. Thank you. So what's the top 10? Of course, top 10 is always highly subjective. So what I felt top 10, someone might feel differently. I was looking at the ongoing trials. I was looking at the publications from 2021 and 2022. I was looking at the recent ESCO presentations from Chicago. And of course, I was also looking at a project we are doing ourselves in Graz. And of course, I'm a surgeon, so it might be a little bit different than the last time when an oncologist was talking. So maybe it's a little bit more surgery focused. So, but the first study I want to talk about is an oncology study. It's a study from Emanuele Palmerini from the Italian group. It's a phase 2 study for non-metastatic extremity high-grade osteosarcoma in pediatric and adolescent and young adult patients. And the question was, is miframoatide or MEPACT, as you know it, is working? And if you look at Wikipedia, what's this MEPACT is marketed by Takeda, a big company. It's a fully synthetic derivative of muramyl dipeptide, MDP, and it has been licensed by the EMA in 2009, but the drug was denied approval by the FDA in 2007. And for those who are longer with sarcoma, there has been a lot of discussion going on for the last 10 years, if it's working, it's not working, if we need more studies or not. And one of the questions the Italians wanted to answer is it working or not? There are some advertisements like this one, Tim Tyler, Living Proof, where advertisement for drugs is allowed. I'm a little bit skeptical if just one survival is really telling us that the drug is working, because it's just a happy person. But nevertheless, I think it's very important that we think or we study the therapeutic benefit, but it's still discussed controversially, also because of the high costs. So there's a big question mark. So if I look at the study, it was a prospective phase 2 study. It was a multi-center study in just Italy. It was uncontrolled. It was all patients up to the age of 40 have been included. It was for non-metastatic G3 osteosarcoma patients. And the interesting thing is they tried to stratify in 2 groups, a low risk group and a high risk group. And the high risk group was those with this PGP, this P-glycoprotein overexpression. It's something for me, it was really new. And those patients which had this overexpression went to the high risk group. This is how it looked like. I can maybe push this a little bit away. Yeah. So you can see here that the 2 arms, so PGP negative patients, so it's low risk group, they got this map plus and the PGP positive also got this MEPACT, and on the high, if they were poor responders, that means more than 10% of the tumor cells still alive after chemotherapy in the surgeon specimen, they got high dose ifosfamide. So high dose ifosfamide for bad histological response. 279 patients who have been included. About 64% of them have been PGP positive, and the mean follow-up was 51 months. And you can see here the bad response with necrosis under 90% have been 65 patients, and 59 had a good response. These are the results. I will not go into detail, but we can see that the patients with a good response to chemotherapy had a good prognosis for 5-year event-free survival over 80%. And those with a bad response had below 60%. And the PGP negative, low risk group, but not stratified for histological response at 66.4%. And you can see here in the graph on the right-hand side, those patients with a good histological response had a better survival than those, or event-free survival, than those with a bad histological response. I think we all know that. So this is nothing really new. If the tumor responds well to chemotherapy, it's a good thing. So the conclusions from the study, and I'll just copy and paste it, it's written, this study showed that adjuvant mifamotide, MEPAC, combined with high-dose ifosfamide for poor response to induction chemotherapy could improve event-free survival in PGP-positive patients. And one of the second conclusions was mifamotide and high-dose ifosfamide as salvage chemotherapy are worth further studies. There are two things in these sentences which are a little bit, let's say, controversial. If you know what's written there, you then see it could improve. So we don't know if it's really improving. It could improve. It's a hypothesis, and it's worth further studies. So again, we don't have a conclusion. And why is that so? Because in this study, we have three things which, at least for me, are worth own studies. Mifamotide, MEPAC, one thing, we still do not know if it's working or not. This risk stratification for PGP positive or not, it's a new thing. And also high-dose ifosfamide. So they tried to answer a lot of questions with this trial. The problem of, at least for me, we have more answers, more questions than answers after the study. So we need more studies for each of those three things, at least in my opinion. The second thing is also a little bit puzzling. It's on infection and overall survival. It's a study from Demosthenes Andreou. The first author is Christine Schwering. It just has been published in Cancers 2022. We all know that if you have an operation and you get an infection afterwards, is a horrible thing. It's horrible because you might need another operation or two operations or three operations. And in the end, you might even lose your leg afterwards. So we all know that infection is a grave complication, but there have been reports that survival might be better if you get an infection early after implantation of the tumor prosthesis, which is crazy because it's normally if you have an infection and operation, so normally your immune system goes down, you need antibiotics and so on. So, but there have been conflicting reports. Some says one says it's positive for overall survival, one says it's bad for overall survival. So, and this survival benefit could be possible a result of the immune inflammatory host response to infection. That's a big question. So Demosthenes Andreou collected 437 patients from Germany and Austria, 5 centers, the median follow-up of 100 months, so quite a long follow-up. And 46 of those patients had an early postoperative infection. That's 10.5%. So normally if you get a hip prosthesis or knee prosthesis, you have an infection rate of about maximum 1. So it's a high infection rate, but we know that's normal for mega prosthesis. So we know that. And if you see it, if you look at the graph concerning disease-specific survival, there is no difference. So no benefit, but also not really bad infection versus no infection. But then there's something really interesting. So this is not significant, there's no significant difference. Interestingly, also no local occurrences were in the infection group, but it's very low number, so we can't say anything out of that. But look at this graph. The green thing is the patients who got an infection after the operation, an early infection within the first 12 months. And the blue ones are the patients without an infection. And you can see here, disease-specific survival, there is a significant difference. And we don't know why. I clearly have to say, we don't know why the patients who got an infection with a bad histological response, why they lived longer. So we don't really know. So again, this is those patients who had a poor histological response to chemotherapy. Not all patients. So the good responders, there was no difference at all. But those patients who had a bad response to chemotherapy, and you look this on the histological specimen, they had a better survival. So the cause we don't really know. It might be the toxin of the bacteria. Is one possibility, but the authors more think it might be an immunological response of the immune system, and then helping also fight tumor cells. But we don't really know. So research needed, and also this could be also a sign that immunotherapy might help in the next years or decades. What I want to tell you, please avoid prosthetic infection because they're horrible and you might lose the leg. But if you get an infection, maybe your prognosis gets better, but we don't really know why. So this, of course, is also a retrospective study, but this is quite interesting. And what we want to see is, I think you might have read the news about this small cancer drug in Washington Post, for example. There's the tumor disappears because of targeted therapy in 100% of patients. So we want to see that for osteosarcoma and Ewing sarcoma, but I think we are quite far away. Now let's move to Chicago. Just a few weeks ago, there was the ASCO annual meeting. That's the biggest oncological conference with over 40,000 attendees yearly in Chicago. And I skimmed through all the sarcoma abstracts. And there are two abstracts I want to show you. One is on poverty and race in osteosarcoma. And it's quite an interesting thing. It's US, so we might think it's all totally different. But I'll show you it's not so different to us. And the question was, has poverty, race, and ethnicity and survival among US children with non-metastatic osteosarcoma treated, do they have an influence? So do poorer children live shorter than those rich children, or the white children have a better outcome than black children, for example? And they wanted to identify the association between race, ethnicity, and proxy measures of household and neighborhood poverty, not only looking at the poverty of the family, but also in the neighborhood. And by looking at event-free and overall survival among those children, it was, of course, a retrospective study. The retrospective study up to the age of 21, looking at the event-free survival, overall survival, and post-relapse survival. And they were looking at poverty exposure, that means neighborhood or your own family, and race and ethnicity. You can see here most of the children included in the study have been white. The yellow ones are the white children, white non-Hispanic. The red one are the non-Hispanic blacks, and the blue part are the Hispanics. And about 28% have been neighborhood poverty exposed, and 26% have been household poverty exposed. And household poverty was associated with young age, and neighborhood poverty, of course, and of course also race and ethnicity. So poverty and ethnicity, there was an association. And you can see here the results. And for me, the results were puzzling because there wasn't really a difference. So no difference for the children included in the study. They have been included in the study concerning survival. I think this is a really good thing. So we can say all children that have been randomized in this trial and have been treated in the trial had the same survival. But then a quite interesting thing happens. If you then look at the relapse, so all the children who got a relapse, that means recurrence or metastasis, then you have a big difference. And the big difference you can see here, the non-Hispanic white, they had a survival of about 40%. The non-Hispanic black had only about 13%. So if the child gets recurrence, then everything goes worse. So there's really a big difference. So primary inclusion in the study, perfect. All have the same survival. It's not a good survival. We all know that. We're not content with that. But if then the children have a relapse, local recurrence or metastasis, then things go south. So that's, I think, really an important message. But is this message also true for Europe? Europe, we know, we think all are healthy and not healthy, but rich. But also in Europe, we have problems. And I can show you. I've shown this graph last year. We have a big difference in Europe concerning overall survival for bone and cartilage sarcoma between the Western countries and the Eastern countries. And it's a huge difference. So it's about 20% difference in overall survival for between Central Europe, for example, and Eastern Europe. And it's the old border of the Iron Curtain. So it's the old border. The countries on the east side of this Iron Curtain have a really worse prognosis than those on the western part of Europe. And I think we have to deal with that, and we have to think about this, how we can, what are the causes for this, and how can we also change this? And it's the same true for soft tissue sarcoma survival, but not in that amount. So it's horrible for bone and cartilage sarcoma, and it's also not really good for soft tissue sarcoma. But the difference here is not so big. I think because chemotherapy is rarely working for soft tissue sarcomas, so I think this is the big difference is chemotherapy, or the appropriate amount of chemotherapy given for those patients. So the conclusion of the third point is poverty influences overall survival in case of relapse. And I think we have a quite similar problem in Europe and maybe also in the rest of the world. The fourth point is also an interesting study on viewing and treatment delay. I've got this graph, these slides from Demosthenes Andreo. Was a study done by Uta Dirksen and Demosthenes Andreo. And the question was the association, or look for the association of treatment delays with an unfavorable outcome in patients with localized Ewing sarcoma. It was a retrospective analysis of the Ewing 99 trial. They were looking at outcome of Ewing sarcomas. Of course, we all try to improve it. And the question was to evaluate the prognostic impact of treatment delays in Ewing sarcoma patients. The question was, do those patients who have a long period between biopsy and start of treatment, do they have a worse outcome than those patients who have it within, let's say, 14 days? And also after operation, if the delay between operation and start of chemotherapy, is it too long? Again, do those patients have bad survival? And we're looking at the GBOH database with those countries involved. 692 patients included. Inclusion criteria: localized disease, so no metastasis, surgical treatment. Interval biopsy to start of chemotherapy was in mean 14 days. So between biopsy and start of chemotherapy, 2 weeks. For me, it seems pretty long, but we will see the results. Surgery after 6 Wheeler cycles, 485 patients. Interval start chemotherapy to surgery, 141 days. So start of chemotherapy to wide resection or resection, 140 days. And then also they were looking at the interval between surgery and start of chemotherapy and 17 days. And I think you, or most of you, will know the Ewing 99 trial. And this is what we can see: significant result concerning event-free survival between interval over 22 days between biopsy and start of chemotherapy, and below 22 days. So if if it's more than 3 weeks between biopsy and start of chemotherapy, the patient will have a worse outcome. And 3 weeks is really, really a long time. And you can see also for the overall survival, it's not statistically significant. The P is 0.06, but it's nearly significant. So again, and also the impact on survival by delays between start of chemotherapy and operation. The longer it takes, the worse the outcome. So also this is quite important that you plan your operation. And also low volume centers, again, had a worse outcome or more problems with those intervals than those with high volume centers. And also the delay between surgery and start of adjuvant chemotherapy. You can see here on the left-hand side, and also on the right-hand side, statistically significant things, results. If the delay between operation and the start of chemotherapy is more than 3 weeks, again, those patients will have a worse outcome. And this is quite an important message. And you can see here again, also what we know: pelvic tumor localization is not doing good. Postological response to chemotherapy is not doing good. So we all know that. But I think the other things I've shown you are really, really important. So conclusion, there is an association between induction chemotherapy and surgery, and the delay is important, and also between surgery and consolidation chemotherapy. So that means after surgery, very, very important. And here the conclusion also, there is a need to optimize supportive care. There's need to optimize referral pathways, and treatment in high volume centers is recommended. And just to conclude in 2 sentences, so no delay, very, very important, and centralization. That means high volume specialized centers who know what to do and how to do it. The 5th study is the Ewing recur study. It's quite an important study from the Ewing group. It's a phase 3 assessment of topotecan and cyclophosphamide and high-dose ifosfamide in recur for patients that have refractory Ewing sarcoma. And you can see here 4 arms. I'm just talking about the topotecan and the ifosfamide. Again, I'm a surgeon, so I will not go into detail. And it's a quite complicated study. It sounds complicated. It's a multi-arm, multi-stage, seamless phase 2/3 drop-a-loose randomized trial with a Bayesian design, with interpretation based on posterior probabilities, with non-informative priors. It's, at least for me, a little bit difficult, but it's a very good thing because normally those patients are pretty rare, and they normally it's pretty difficult to get them into good studies. You can see here 16 countries involved, 2 continents. Unfortunately, not my home country, Austria, but I hope we can change that. And we can see here that already 162 patients have been allocated to the topotecan group and 78 patients to the fosfamide group. And these are the first results. And it seems that high-dose fosfamide is doing a good job for those patients. And fosfamide is effective in the first-line relapse disease. And this is the first controlled evidence of its superiority at relapse. And the author should be commended for the efforts. It's not a conclusion of the authors, but of a summary of all those studies. And survival outcomes highlights the urgency to find more active and less toxic agents. And also the trial continues, so it's not closed, it continues, and urge to also please help us include patients, because normally it's a dismal disease. This Euro-Ewing consortium is very active. It's a highly active group, and I really thank the group for the efforts. And the outcome, unfortunately, for recurrent Ewing sarcoma is still dismal. The next thing is a little bit shorter. It's on Ewing sarcoma and liquid biopsy. Why shorter? Because after my talk, you will hear another talk on liquid biopsy from a professional, from Eleni Tomasou. And I'll just go briefly over it. So there are more and more studies coming now that also for sarcomas, liquid biopsy is of importance. What is liquid biopsy? Liquid biopsy is if you have a tumor, you take a tumor sample, and in this tumor, in this blood sample, you can then find tumor DNA or tumor cells, depending on your methodology, and then you can monitor the disease just taking blood. That's the good thing. You might, in the end, not need any more big CTs and anymore for routine follow-up. Just take blood samples and just check if the tumor DNA here is high, is it there, or is it absent, which would then be a good sign. And we've included this technique for our children in Graz, and my colleague Professor Seidel is doing this, and this is what we want to look at it. So surgery, this the blue thing, and then it goes down. The tumor DNA, and it stays down, and we don't have a recurrence, so no metastasis, no local recurrence. This is what we don't want to see. It went down, the levels in the blood, and then they go up again because of distant metastasis. They go down a little bit again because some metastases are resected, and also the child got chemotherapy, but in the end it's still up, and we never go down to a 0 level, and then the patient dies. So we introduced it in the routine. I think it's a really good thing. Of course, it's at the moment experimental. It's early detection of recurrence. Is it really helping for prognosis? That's a pretty good question. And at the moment, it's it's very cost intensive. So, but I think it's really helping the patient, because if you just have to give blood all 3 or 6 months, then it's really helpful in doing the chest CT, abdomen CT, and so on. So this might really change our routine life in the next 10 years. So it's going to the routine, but what about the costs? The 7th point is on chordomas, also bone sarcoma, and you can see here this is those ugly big tumors, especially in the sacrum. And you can see here, normally we have done surgery for these, but you will have then recurrences, because you can see here there are multiple foci. And the Italians developed a very nice study looking on surgery, big surgery, versus definitive radiation therapy. So only radiotherapy only. Leave the tumor inside, just give proton or carbon ion radiotherapy for primary localized disease. Alex Ronke designed this. You can see here, big operations with very high morbidity afterwards, because you have big surgery and you normally cannot really reconstruct it, versus radiotherapy. It is an international multi-center comparative open label parallel group mixed observational randomized controlled trial. Also sounds difficult. To say it simple, all patients can be included. Also, if the patient says, I don't want to be randomized, I want to have radiotherapy, we can include this patient. Also, when the surgeon says, I don't want to really do surgery in this case, I want to have radiotherapy, we can include this case. So this is really, really good study. So far, over 100 patients have been included. You can see it's a really rare disease. Only 1 patient per month has been included. But I think the study goes on, is planned till 2024 because you need a follow-up of all those patients. You can see here the centers are including mainly Italy, Norway, Spain, Austria, Japan, Germany, Essen. And yeah, I think it's a really good study. Also, quality of life is one of the topics we're looking in the study. And the tumor can be out after sacrectomy, but if the quality of life is really good, I'm really skeptical. So primary outcome measures, relapse-free survival, local disease, and death from any cause. You'll notice this is the patient I'll show you, 69-year-old male patient, and this is on the right-hand side 3 years after radiotherapy. The tumor is still inside, it shrank a little bit, but the patient is nearly complaint-free. So at least for him at the moment, it was really good decision to do radiotherapy. But we will see in the end how most patients did. So chordoma and sacro study is an active study, and the results will be really, really interesting. The next thing is a benign tumor, it's giant cell tumor of bone, but it can rarely metastasize, and also the oncologists treat it, so it's a little bit of mixture of benign and malignant. It has a high recurrence rate, and we are using, or we're using denosumab. Denosumab is also used for bone metastasis for cancer, for example. It really had great hopes at the beginning, because it seems the tumor stopped growing, they calcified, and everything was fine. Now we have more doubts than hopes, because the problem is the tumor cells don't die. They kind of sleep there, and when you stop denosumab, they grow again. And it seems like the tumor is then growing more actively. It's at the moment used for complex and inoperable disease. And the question was, if you have a really big tumor and you don't want to resect it because the patient then has a high morbidity, again, sacrum, for example, you would have to give denosumab for a really, really long time, and all 4 weeks. But this has also disadvantages. There is you have problems with the osteonecrosis of the jaw. You might have pathological fractures due to at the long bones, for example. And this was one of the studies published this year, tried to increase intervals between giving denosumab. And you can see here in about 40% of patients, it was increased up to 12 weeks. And the bone complications, still 5 osteonecrosis of the jaw, 1 atypical fracture, and non-healing dental wounds, but a similar tumor control. So it seems like we can increase the time between giving denosumab. So inoperable disease, lengthened intervals. The 9th study is designed from the French, Jean-Yves Blay, and it's really an interesting study. Again, it's a real-world European registry, not a study, a registry of those NTRK fusions and other rare actionable fusions. What does it mean? Some of the patients have really, really rare fusions. Really rare fusions that can be helped to identify possible targets for targeted therapy. And it seems like some of those patients can live longer, and we might even have a cure for some of those patients in the future. That's why we need to understand more those patients with those rare fusions better, because we have to learn and improve treatment. You can see here there's an extensive list of those fusions. Most of the fusions are not sarcoma associated. They are more lung cancer or colon cancer or malignant melanoma or breast cancer. But some of those are for soft tissue sarcomas, and some of those are also for bone sarcomas. And it's really, really interesting, especially for children with those rare fusions. We sometimes have already targeted therapy for those fusions. These are the countries involved, and we hope to screen for fusions. I think it's also very important. And the last point I wanted to briefly talk about is quality of life. We've had a session beforehand, and I just wanted to go briefly about it. Personally, as a surgeon, sometimes I wanted to save the limb, or often wanted to save the limb, or nearly often wanted to save the limb. And especially below the knee, we did a lot of operations, especially for osteosarcoma of the calcaneus, for example, and we really tried hard to save the limb. And sometimes then you have the problem that it's not done with one operation. You have to revise it, or you need a plastic surgery, and then maybe the patient has a fracture and so on. And in the end, sometimes I had the feeling that the quality of life after all those operations was maybe a little bit better or as good as if we would have done below a knee amputation from the very, very beginning. That's why we did a study with 69 patients with ankle sarcomas from 2 centers. 36 of those patients had an amputation at the very beginning for those ankle sarcomas. 64 patients had limb salvage, some with major surgery, some with small surgery. And the median follow-up was 5 years. And we had a really high complication rate for those major limb salvage surgery group of about 60%, but the quality of life was comparable. So I think it's important if you as a patient or as a parent of a child, discuss it with doctor, and he wants to do surgery, also ask, is the quality of life after the operation really better than with a simple operation, but an ablative operation? And it was really an interesting consensus meeting now in St. Gallen some weeks ago. It was a hybrid meeting, 13 presence, 100 online. And you can see here also the countries involved. And one of the questions where we tried to get a consensus there was, in general, my main aim of palliative treatment in asymptomatic patients is it prolongation of life? Is it prolongation of progression-free survival? Or is it maintenance of quality of life? And you can see here, most of the delegates said, quality of life is the most important thing for my patients. And I think it's even more important to think also, or talk about those quality adjusted life years, because it's not the, we heard this in the session before, it's not the years so the patients live or we live, of course it's the years, but it's also not only the quantity of years, but also the quality of the years we live. And so I think this is really, really important and should be implemented in nearly all studies which planned at the moment. So measure of disease burden, including both the quality and the quantity of the life lived. So quality of life plus overall survival. In conclusion, we can deal with bone sarcomas and improve treatment only together in multicentric international trials. And in the end, I would like to invite you also to the ASOS meeting in Los Angeles, and especially to the EMSOS meeting in London. Thank you very much.
Thank you very much, Dr. Leithner, for this comprehensive overview. Many stimulating topics and several unanswered questions. That is to say, a lot of work to do. Are there questions in the room? Catherine? No. I have a question about a general topic. Global collaborations are crucial in building evidence. Which are, in your experience, the main obstacles of such collaborations? And what can we do to overcome barriers?
I think meetings like this are extremely important for building those collaborations. So it's sometimes a little bit more difficult in hybrid meetings, but I think especially meeting and talking and thinking about the questions we really need to answer is extremely important. Especially the Euro group the Euro consortium is extremely active. So I think these are really good consortiums that should be funded, that should be focused on, and should be supported.
Thank you. Professor Uta Dirkensen has a question for you.
Hello, Andreas, great talk, and thank you for strengthening Ewing sarcoma, which is, of course, a most important disease. No, just kidding, but I'm just a Ewing person. I just also to make it clear for maybe all patients or people who have contacts to patients, I would like to give one additional comment to the recur study. What you have to know is that the study is designed in a way that if one arm has no chance to become better than the other arm, then it is skipped. And that does not mean that, for example, irinotecan, temozolomide, topotecan, cyclophosphamide are regimens that completely do not work, and that like every patient who has received that was treated in a wrong way. I think the only really major difference was with docetaxel in that arm. So they are also active, but high dose ifosfamide really was the one who left, and that was kind of slightly better. And I think that's just important to know for all patients who know people or who may be treated in that way by themselves. Yeah, but it's an important study, and it was interesting to all of us that high dose ifosfamide performed so well. Yeah, and just concerning your liquid biopsy study, it's absolutely cool that you are also starting that now in Graz. I don't know whether that's the same protocol that we used with Markus Metzler together, and I think it would be great maybe to join forces, because we will need to test a lot of patients before we really can be sure that we may be able to use this as a prognostic marker. So maybe like your person could if helpful, come back to us, and we could possibly join forces, because we have tested already kind of few, but I mean, you know that, yeah.
With pleasure, thank you.
From my side.
Another question online, and hands up, please. Sikoi.
Hi, good afternoon all. Andreas, thank you very much for an excellent presentation. Two things. I have the feeling that the organization of care, centralization for the bone sarcoma should be a priority for those countries where it's not in place yet. I think that's, especially for the bone sarcoma, is very important. Even in the Netherlands, where it's quite well organized and 87% of the bone sarcomas is treated in one of the 4 centers, things can go terribly wrong. So I think that's really, really important for well, the overall survival and quality of life from every patient with a bone sarcoma. And secondly, about the chordoma study, I know the Austramed facility in Wiener Neustadt is actively getting patients to not have surgery and take the carbon ion radiation instead. Something that in the near future as a standard treatment for sacral patients? Yes,
I hope so.
Okay.
I'm a surgeon, but sacrectomy is not a surgery I want to have on my own. So
no, I understand. Yeah. Okay, thank you.
Any additional questions? No. Thank you, Dr. Leithner. Thank you for your presentation. Let's move on to the next presentation.